you so much. It's my absolute pleasure to be here. And I have to say, I wish I had a little bit more sound in my slides after this first start. But I think it's such a great start to a fantastic celebration of 50 years. And that's really special. And when you get a group of people together that are very, very intrigued and very interested by helping patients and getting better at what they do, I think that's a really special thing. So I feel very, very chuffed to be able to come here and speak. So the talk I'm going to give today is I want to, I guess, challenge our idea of what pain is. And I think what I'd like to focus on, or what I'd like you to take away from this morning's message, is a real appreciation for the terrible but wonderful complexity of pain. Terrible in the sense that it's really hard to treat people that are in chronic pain. It's really hard. But wonderful in the sense that the more that we understand about all of its little intricacies and different things that are going on, the more ways that we may be able to target it. And so what I hope to do today is to give you some examples of what I think highlight the complexity of pain. Also give you a little bit of background of what we know from pain neuroscience, and then how that might be used to start to develop and to implement new types of treatments that I believe are really relevant to allied health professionals such as ourselves. So you'll see I've added what's between your ears is more important than your sore back or knee, because I have some new findings on knee osteoarthritis that I'm really keen to share. But what I would like to do is to give you these new insights about pain neuroscience. So where do I point with this? Nowhere? Is it on? It's on. So my background training is actually as a physiotherapist, and when I worked clinically, one of the things that I found most challenging is that if I saw someone's imaging findings, I really couldn't predict how much pain they were going to come in to see me with. It just didn't match up. And this is just an example, I think, that highlights it. These are two different people that have been diagnosed with osteoarthritis of the knee. And you can see the one on your left. It's a pretty shocking looking x-ray that disappeared. So you can see that it's bone on bone. You can just imagine the creaking, grinding, awful pain that they'd probably feel when they're walking. However, the one on the right, it actually doesn't look too bad. Oh, thank you. In that one, you can see that there's quite a bit of joint space. I would say it's only very mild osteoarthritis. And yet, both people come in with a pain of about 5 out of 10 that's very osteoarthritic in nature. And this finding really challenged what I believed, I guess at that time, pain to be, in that it was an indicator of how much joint damage is there or what is going on in the tissues. And instead, findings like this, what they suggest is that process is so much more complex. In fact, that the amount of tissue damage doesn't relate very well to how much pain people experience, suggests that there are other factors contributing to that pain experience. And that's really when I started to consider, well, what is the role of the brain and the nervous system in generating this experience of pain? And these same findings, they hold true for back pain as well. If we look at, and I think it's starting to be quite well known, if we look at MRIs of the back, we know that they're very sensitive. They're very good at picking up little things, but they're not necessarily specific in that what they find will relate to the symptoms that people have. So for example, if we took all of us that didn't have any back pain today and put us in a scanner, 60% of us who don't have any pain at all would have evidence on that MR scan of disc pathology. So to use that as an indicator often of what's going on to explain the pain experience, in some cases it's relevant, but in a lot of cases it isn't, and it actually doesn't tell us too much. I guess what I'd like to do is introduce this idea that everything is so complex. Our brain produces our sensations according to the credible, believable evidence that is present, not just according to the sensory information that's coming from that body part. And I'd like to highlight that with a couple of different examples. So this is a case study. It was published in the BMJ, and I really think this may have been why I went into research, because it was just a fantastic case study. Obviously, this poor fellow had a bad day at work. He managed to skewer his boot with a nail. And so quite understandably, he was in a decent amount of pain, had to be taken to the hospital, and when they got there, anytime they touched that foot at all, excruciating pain. So he had to be given, painkillers, sedatives to try to help control his experience. And then it was to everyone's surprise that when they removed the nail, they realized it went between his 2 toes. But he was experiencing pain. Believable, credible evidence of vision told him that his foot was in danger, and therefore the appropriate output to protect the body is to elicit pain so that you don't move that further, so that you don't step on it anymore, and you allow yourself to be treated appropriately. And that is fascinating. So our brain is there to try to protect us from either real or perceived danger, and the way that it does that is pain. Now, there's a lot of other things that can influence how much pain we experience. And this is a really cool study that illustrates that. And this was out of some colleagues from Oxford did this study. And they were testing how much expectation of pain matters to the pain experience. And so what they did is they actually were testing an opioid called remifentanil. So people were getting this opioid via IV, so they didn't know when they were going to get it. Now, as in all pain studies that are incredibly fun to take part in, they burned them and then saw how much it hurt. Don't volunteer for pain studies. But you can see there that it's about 65 out of 100. It's a decent amount of pain in terms of intensity. And so then they said to participants, okay, so actually, sorry, we didn't record that last one. We better try this again. Sorry, we're going to turn this on again. I'm going to get this pain experience again. But they didn't tell them that they had actually started to give them the opioid. So they have no expectation. And this is what they found. Thank goodness, an opioid decreases pain, but it's not very big. It's about 15 points on that 100-point scale. So then what they said is now what we're going to do is we're going to turn on the opioid. So you should expect that the pain that you experience will be less when we give you this burning stimulus again. And then this is what they found. An even larger reduction in pain. So as soon as you add expectancy of pain relief, that effect is magnified. And then this is my very favorite part. Then they told people, all right, we can't leave you on opioids for very long. I know it's really good and really fun, but let's take you off them now. We're going to turn off your opioid supply, and we're going to burn you again. And you can expect that that pain level is likely going to return. It's going to hurt. But they didn't turn off the opioid. It completely abolishes any effect of an opioid. And I think that's important because when we have people that are chronic and suffering from many different conditions, they often have failed a lot of different treatments. And they may come in with negative expectations. And you can see that negative expectancy completely obliterates the effect of an opioid. So that's something that we really need to target, I think, as clinicians. And what's interesting about this study as well is you might say, well, it's just biased ratings because they already cued them as to what they probably should say in terms of pain scores. But they actually imaged these people's brains at the same times, and the amount of activity that was occurring correlated very well with their ratings. So it does suggest that indeed the entire process of creating the experience of pain was different. And then when we look at clinical conditions, this becomes an interesting thing to consider. So this is a picture of someone who has complex regional pain syndrome. A pretty rare condition, but it most often occurs after a limb fracture. And it's not a fun condition to have. It's very painful. There's motor movement problems. It swells. The skin changes. But when we test these participants, what we find is that they have a very sensitive system in the sense that when you touch their hand very lightly, it's often painful. They have allodynia. Or when you touch other parts of their hand, it'll actually result in a feeling of paresthesias or pins and needles. And so in this study, what they did is they mapped out the areas of that person's hand that when they touched it very lightly, they had pain or they had pins and needles. And then they said, what if we just made them perceive that there's danger to that hand, but not actually touch it at all? Could we elicit those sensations? And so what they did is they gave them a virtual limb. And they did that using mirrors. So their good hand was on one side. The CRPS hand is hidden behind the mirror. and then they see a reflection of their good hand in the mirror, and it appears, for all intents and purposes, to be that CRPS hand because it's in the right place. And then what they did is they touched the good hand. So again, it looks like to the person that their bad hand in the reflection in the mirror is being touched. And when they touched that pain-free hand in certain areas, it elicited pins and needles in the CRPS hand. When they touched the good hand in other areas that they'd already predetermined, then it elicited pain in the CRPS hand. So we have people with CRPS feeling pain without anything touching that affected hand. And what that suggests, again, is that when believable, credible evidence tells you that your hand is in danger, the appropriate response is to protect it and to produce pain. And so we see how complex this is. There's one last study that I think is quite cool that I'd like to share that is done by Daniel Harvey, who now works at Griffith as a postdoc and apparently likes pickup sticks. But in this study, what he was looking at is people that had mechanical neck pain. So these are people that very reliably, when they turn their head to a certain degree of rotation, pain comes on. And in those people, I tend to think, in my mind, what I picture is something's pinching in their neck. Something's going on that every time they get to that exact motion, they're getting the pain. But what he said is that the case? Or is it that they've had so many cues that certain areas of space are actually dangerous that potentially that's why they're having pain? And so what he did is he had them wear video goggles. And they did neck rotation, and he very carefully measured how far they rotated their neck. And they saw a scenery somewhat like this. Now, in this scenery, it would move as they moved their head. So just as if you were scanning the room, you would see different parts of the room. That's exactly what they saw in the video goggles. But what he did is he said, what if the eyes lie to people? What if they don't give them the right information about how far they've actually moved their head? So he manipulated what they saw. So in some cases, the eyes lagged behind, the vision of what they saw lagged behind, so they'd moved their head further than their eyes were telling them. Or the eyes moved quicker, so that their eyes are telling them, you've moved your head further than you truly have. And he measured that point at which pain came on in the motion. And so this is what he found, is when what the eyes are telling you about motion is accurate, people could tend to move about 50 degrees into rotation before neck pain came on. Now, when the eyes were too slow, when the eyes are telling you you have not moved your head as far as you actually have, people could move significantly further before they had that onset of pain. And this just wasn't the fact that, oh, maybe they've done it a couple times, now they're just getting used to it. These were all done in a random order. But I think the most interesting one and the most telling one is that when the eyes told you that you'd moved your head further than you actually had, pain came on much sooner. So when the believable, credible evidence is telling you that you've moved your head too far, you're in danger, the appropriate output is pain. So it makes sense then to go back and try to understand a little bit more about the neurophysiology of how that experience of pain is actually created, because we can see there's a lot of examples where it doesn't just relate to the fact of how much tissue damage, because for example, the neck pain people, there's no more tissue damage, it's staying the same. But if we think about an acute noxious stimulus, so let's say you step on a thumbtack, and we know that that will activate specialized receptors called nociceptors. That message will be transported via a primary afferent to the spinal cord, which synapses in the dorsal horn of the spinal cord, and that message is then transmitted up ascending pathways to the brain. But I think what's one of the most important things to realize is that that message at that point isn't pain. It is not a pain pathway. It is not a pain message going up to the brain. It is a message of danger or threat. And the brain then has to take that message coming from the periphery and combine it with all the other things that are going on, such as vision, such as past experience, such as expectations, such as beliefs. and then determine whether or not an output of pain is justified. And we think the brain makes those decisions by asking questions such as, is this stimulus dangerous? Will it damage my body? Do I need to do anything about it? And where is the stimulus actually occurring? And then based on the answers to the questions, it decides whether an output of pain is appropriate. And of course, what we know now is that it can also exert what we call top-down descending effects on the spinal cord. And these effects, they can be facilitatory. So it can be, I stepped on a thumbtack, this is really important, I need to pay attention to this. That's it. Make this message very easy to get up to the brain. Let's make it so that the sub-threshold stimuli can now activate this pathway, and I am getting every single piece of information about what's going on there as possible. Everything becomes sensitive. Or it can be inhibitory. So it can say, I thought I stepped on a thumbtack last week, but actually it was just a little stick on my foot. Don't worry about it. Settle down, nervous system. And it settles everything, makes it more difficult for that message to get up to the brain. And so oftentimes we try to take advantage of this system when we try to use some of our different brain-directed treatments. But this is also a case of acute pain, something where you've just literally had your tissue damage. And of course, it gets inherently more complex when we talk about chronic pain, when often that site of tissue damage may have healed. And this is where it starts to get murky, but important. But we know that in chronic pain, we get central sensitization, which in general terms means that everything is more sensitive. So when primary afferent synapse in the dorsal horn, that connection, sub-threshold stimuli can now activate it. So before, maybe it would have taken 2 impulses each a second to be able to activate that synapse and activate that sending of the message up. And now maybe it only takes 1. It also means that things like touch information can also elicit and activate this pathway. And it's interesting because it's this idea of amplifying the signal. So if we think about a radio, if you turn up the volume, it doesn't actually mean that the person speaking is talking any louder. It means you've amplified his voice. Just like when central sensitization is going on, it doesn't mean that there's actually more tissue damage. It just means you've turned up the volume of the signal. And then this makes more sense why we get such a disconnect between how much pain people feel and the actual tissue injury, because that signal going up to the brain is actually no longer reflective of how much tissue damage is there because we've turned up the volume. What's more is in chronic pain, we see alterations in this descending modulation. In things like osteoarthritis and fibromyalgia, we know that that descending inhibitory system doesn't work very well. It's not doing its proper job to say, settle down, this isn't a big deal, it's just a stick, it's not a thumbtack. It's not doing its job to tone down the system. And what's more, what we're starting to understand is when we think about supraspinally, when we think about the brain, we know that things that fire together wire together. Neurons that are always firing together start to have functional connections that makes them much easier to activate in concert. So this might be things such as if someone's afraid of bending, they have a sore back and they're feeling a bit nervous and anxious about needing to bend and lift to pick up a box. Okay, so all the areas that activate with anxiety start to also activate with this nociceptive stimulus, maybe coming from the back. And they get very good at firing together. And now all of a sudden, even when you're anxious about something else, you feel pain in your back. And we think that's because of the functional connections between these different networks in the brain. And that's what makes our job so hard. But why does this all matter? Well, I think if we do think of this person who has back pain and they're going to bend over to lift to pick up a box, let's say that little graph, it has no units, I've literally just made it up, but let's say generally that's how much activity there is in the nociceptors in the back. It will give a little bit of activity when he bends over. But then, he saw an MRI of his back, and he saw a bulging disc. And you know what it looked like? It looked like it wanted to pop. And I bet you if he bends over really fast, it might. But then he also talked to his doctor. And his doctor said, oh, did you know one of the most common ways to blow out a disc is by bending over to pick something up? Now that representation is part of this motion and this action. And then his vision cues him, well, he's going to do this motion, and it says, you've been in this position before. The last time you were in this position, you had a massive flare-up and you couldn't go to work for a week. This is danger. And so what we get is when all these different things coalesce, you get this massive output of pain that doesn't correlate or isn't explained by the level of nociceptive activity. So then you get fear, you get trepidation of doing things when you believe that how much pain you feel is indicative of how much tissue damage is present. And what's more is that when you believe that, we know that it can make the system more sensitive. So now that message coming from the back might be amplified. That volume knob might be turned up. So we see this circle, this vicious circle that can occur, that what we do is we try to obviously prevent before it happens. Now, if we go back to how the pain experience is created, one area that we've started to pay attention to in terms of targeting for treatment is this idea of how someone determines whether a stimulus is dangerous or whether it could damage a body. How do you determine, and what do you think about pain? And this is really where this idea of explaining pain comes in. And there's been a lot of work over the last 15 years. Indeed, there's been a recent systematic review looking at this, also a nice critical review that was done in the American Pain Society, Journal of Pain, looking at the 15 years of what's been going on in research in this area. But it's the idea of talking through literally what we've just done today. The fact that when the volume knob is turned up, what you feel and what gets up to the brain is not indicative of how much tissue damage there is. So when you feel pain during movements, because you feel more pain does not automatically mean you've done more tissue damage. And having people understand that and truly understand the neurophysiology behind that is really helpful because it gives someone a story for their symptoms. It gives them a reason why they get these really crazy pains that cannot be explained. And when we look at the evidence for explaining pain, what we see is that it supports the use in chronic musculoskeletal pain conditions. It has evidence that it reduces pain in some conditions. It evidence that it overall reduces disability and improves function. It increases patient knowledge of pain, of course, but it also reduces the psychosocial factors, so things like fear, anxiety, catastrophizing. Enhances movement and also minimizes going and utilizing healthcare services. So it's a pretty wide gamut of effects that this can have. And I'll show you one trial, talk you through it, that directly looked at explaining pain, and it was in people who had chronic back pain. And people were randomized to two groups. One group got a 3-hour session of explaining pain and literally getting home the signal or getting home the message that how much pain you experience is not indicative of how much tissue damage there is. Or the other group got general back education, like probably many of us learned at some point in our careers where proper posture and technique is important to reduce stress on the back. And both were 3-hour sessions. And what was interesting is in the group that got this explained pain, their movement improved immediately after the session. So the amount that they could bend forward improved. The amount that they could lift their leg, their straight leg raise improved. So did their pain knowledge. They had better ideas that pain can be controllable, but also that pain doesn't equal harm necessarily. And also that emotions, things like anxiety, stress, fear, they can influence how much pain you have through physiologically changing or modulating the system. They had they sought care less, and also had reductions in their catastrophizing score as well as their disability score. And in this trial, there was no effect on pain. There was a small decrease that wasn't significant in the explained pain group, but it does suggest that there are these nice features that are able to impact a person's life. And I think as allied health professions in general, we're very well placed to be these educators because we spend time with patients and we have good chats, and we can have that time often. Where the field, I guess, has kind of moved in the last little bit is certainly recognizing that's very important, but also understanding, are there other things that contribute that we might be able to target? And it's come to this idea of the importance of how we know where something is occurring on our body. And that sounds kind of silly because it's sort of like, well, I have pain in my elbow. It's my elbow. But of course, it's not that simple because it's humans and we're inherently complex. So when we look at how we actually know what's going on in our body, we know that our brain holds a representation of our body. So we have a representation of touch in our primary somatosensory cortex that allows us to localize touch on our body. And that information is combined with information about where our body is in space. It's combined with information from vision, from movement, what we're currently doing, what we've done in the past, and also vestibular information, or information from where our head is in space. And together, this forms a dynamic representation that allows us to know where we are and space begins and how we can move and interact with the world. But where this becomes interesting is this goes wrong in chronic pain. So when we look at people who have painful hand osteoarthritis and we give them pictures of their hand, and some of the pictures are too big, some are too little, but we tell them, you choose the picture which best represents the proper size of your hand. And what we find is that they significantly underestimate the size of their hand. They choose a much smaller picture than what healthy controls are choosing, suggesting that at a base level, their feeling of their own hand is affected and seems to be altered. And not using the same test, but we see a kind of a similar thing in back pain, in that if you give people a picture such as this, and you say, it's as if you're looking at your own back, and we ask them to draw in where they perceive the edges of their trunk to be. If people have left-sided back pain, they're really good at being able to draw in that other side of their back, the right side. But they're bad at being able to draw in the left side. It's as if they just say, look, this sounds silly, but I can't tell you where that is. I can't tell you where I end and space begins here. I'm not able to do this. And so it suggests that as in this condition of back pain, they as well have altered perceptions of that painful body part. And this altered perception extends to touch. When we measure 2-point discrimination threshold, so this is touching people on the skin with 2 points and determining the smallest distance at which they still feel 2 points and they don't perceive as if you're only being touched by 1 point. And this is representative of how well that body part is actually represented in the primary somatosensory cortex. And what we see is that in painful knee osteoarthritis, when we look at the acuity of their touch perception at the knee, it's much worse than both another pain control sample and healthy controls. So there's 45 millimeters between points, and for them it feels like they're being touched by 1 point, compared to 35 to 34 millimeters in healthy controls. And this altered perception of touch also occurs in people with back pain. So this is, again, using 2-point discrimination. This is just showing you that in 5 of the 6 people, they can't find their back in the areas of the pain. And those are the exact same areas in which their touch perception has gone haywire. They're not good at localizing where they're being touched. What's more is we see that movement-relevant brain maps don't seem to be working correctly. And in knee osteoarthritis, when we give them pictures of feet and lower limbs, and their task is to identify, is that a left foot or a right foot? And we know that task itself activates motor maps in the brain that help us plan movement. People with knee osteoarthritis are significantly less accurate. They only get it correct about 60% of the time, as compared to age and gender-matched healthy controls, who get it right about 90% of the time. So these movement maps are very imprecise. And we see this same thing with back pain, is that if you give them pictures of trunk rotation and they have to say whether the trunk picture is turned to the left or the right, what we'll see is these are people that have current back pain, and the black square to the left of it is healthy controls. They don't differ from healthy controls, But if you have a history of back pain, you're significantly less accurate. But if you have back pain and you've had it in the past, you are much less accurate than all of the other groups, suggesting that these brain maps that code for movement aren't working well. So despite the painful condition in this case, we're seeing parallel problems with body perception, with touch perception, and with movement. And so then this raises the possibility, well, first of all, who cares? Maybe they weren't ever good at this. But the odd thing is, though, is if we target this and we try to make them more precise, pain reduces, which is really odd. And we do this, we target them by doing things such as what we call laterality retraining. So literally giving them pictures, let's say if they have a painful foot, of feet and getting them to choose whether they're left and right and activate some of those brain maps that help us plan movement. Getting them to imagine different postures of movement, what it feels like to go into those postures. And as well, using mirror box therapy. So this idea of having the affected hand or foot behind it and watching normal movement of the good hand, that reflection, so it appears to be that painful hand. We also target the tactile systems by doing things called sensory discrimination training, which I'll talk through in a moment. And we make that harder by having people have to recognize patterns that are drawn on the skin. And we know that this, when we do training like this, it improves how well touch is represented in the brain. So I'll show you some trials that look at results of these. So this is one in that condition called complex regional pain syndrome. But this is when we target the brain using these motor strategies. So this is using the left-right judgments, imagined movements, and then mirror box therapy. The people in the dark circles, those are the ones that received brain-targeted treatment, trying to increase precision of touch and movement. And you can see that their pain scores go down, and they are significantly lower than people that get usual care. And what's intriguing is that when the people that got usual care then switch over, they have these similar reductions in their pain scores, which suggest it wasn't any differences or anything between the groups that were causing those differences in outcomes. But together it suggests that when we actually target the where is it occurring, it seems to impact pain. When we look at targeting touch, this was again in CRPS patients, but it was looking at how well they could localize one of 5 points being touched. And their job was to say what point is being touched and what type of stimulus is being provided. Is it either a tiny little skinny probe or a big fat probe? And they did 24 minutes of this training a day. And this is the results. The top graph is their pain levels. The middle graph is that 2-point discrimination threshold, where smaller values mean better ability to discriminate touch, and then functions on the bottom. During the wait period, so nothing was being done, just measuring these outcomes twice, you can see quite clearly that in none of the outcomes there's any change. All the subjects did just a stimulation period, where all they did was just touch the hand. They didn't have to do any discrimination. They were told to pay attention, but you never know if they did. We have no changes again in outcomes. However, as soon as you have to discriminate where you're being touched and also what type of probe, there is an effect. So there's a significant reduction in pain, a significant increase in function, and you can see that the improvement in their ability to localize touch parallels that pain reduction. So it suggests that there really is this intricate relationship between pain and precision. And what's quite cool is that these effects lasted at the 3-month follow-up period. So there were similar pain, function, and 2-point discrimination values. We've also tried this in back pain. So this is just findings from a pilot study where 12 weeks of sensory and motor precision training were used in these participants. And so they had had chronic back pain for probably 6 to 10 years, I think was the average in these participants, or the range in these participants. And you can see in all of them, they had quite large decreases in pain. Now, of course, we take this with a grain of salt because it's just a pilot study with a couple people and no control. But we've been lucky enough to receive some funding from NHMRC to do a really large randomized control trial on this. So I'm going to say in 3 years, we'll have those results and be able to tell you for sure. But what this research in general suggests is that targeting how the brain codes for the location of stimuli on the body and how it codes for how well you know where your body part is in space, it's important in the pain experience. It reduces pain. Now, one of the challenges with these type of treatments is the dosage of these is so hard to reach. So it's practicing these, for some of them, 5 minutes every waking hour, which for a lot of people isn't feasible. And we think that probably, there was recently an audit that looked at how well these work in the clinic, and we don't see these size of effects in the clinic. And likely, we think it's due to these reduced dosages. So what we're also thinking is, what are other ways that we might be able to target the brain? And this is where there's been some really interesting information from experimental pain science come in. And it's this idea that body-relevant information can modulate pain. So when we think about when all those different inputs come together to create our sense of the body, nociception, that danger signal, is part of that. So this is an experiment where what they did is they had people either look at a reflected image of one hand or look at a reflected image of an object, or in the second experiment, just look directly at their own hand or directly at an object. And all they wanted to know was, does literal vision of your body alone, does that modulate pain? And what they found was yes. When you view your body, and they were zapping people with lasers for this one, so nice, isn't it? There was significant reductions in both intensity and unpleasantness of pain that were consistent across both of those experiments. And what's quite cool is when they imaged people while they were doing this, what they found is that the amount of activation that occurred in the brain in response to that laser zap was significantly reduced in a lot of areas, suggesting that there's modulation of that signal itself occurring. But also that the areas of the brain that make your feeling of your own body and the areas of the brain that nociceptive signal travels to, they're talking better. They're more connected. And that suggests that there's potential that that's modulating that signal. And so we've used this and said, all right, so if body-relevant information can modulate pain, and if people have these weird feelings about their body, they don't really know what size it is, what if we manipulate that? What happens? And so we've looked at illusions in musculoskeletal pain. Particularly, I'll talk about osteoarthritic pain. But in this case, what we use is this quite fun machine called the Mirage. And it was invented by, from the University of Nottingham in the UK by Associate Professor Roger Newport. And in brief, it manipulates real-time video. So what's cool about that is that you put your hands in, you move them around, you see that they're your own, but they will change in front of your eyes in real time. And it's quite compelling. I'll give you a show. So you put your hand in, all of a sudden we start to pull on the end of your finger, and this happens. So as we visually elongate that little pull, what we're doing is we want to give believable, credible evidence from vision and touch that your finger is truly growing. And you consciously know it isn't, but it sure feels like it is. And we also do an illusory shrink, where you push on the end of the finger as it gets smaller. And this was tested in people who had painful hand osteoarthritis by colleagues of mine in the UK. And what they found is that these illusions, when performed over the painful joint, they reduced pain by about 25 to 35% immediately. And what's interesting is it reduced pain in 85% of people and also completely eliminated pain in 1/3 of people. Now, the important part to this is that they also did this illusion over a non-painful area of the hand and said, look, if we just do it anywhere, will it affect pain? And no, it won't. And that's quite nice to know, is that it suggests that it's not just the fact that it's a cool machine that's causing this effect, but that there's some specificity to it. And so I was quite interested to see if this applies to people with knee osteoarthritis, primarily because you get people with osteoarthritis, they're in a lot of pain, they find it hard to exercise, so then they often can't exercise as much, they end up gaining weight, and then it's even harder to exercise because it's even more painful when they weight bear. And I wondered, could we break that cycle somehow? Could we help reduce the pain and maybe stop that cascade of events occurring? And so we use these illusions in knee osteoarthritis. And what you're going to see in the next video is it's as if you have your leg stuck out straight in front of you and you're looking down at your own kneecap. So in a moment, it's going to start to traction and elongate, and we gently pull on the knee or on the calf. So again, you have this believable, credible evidence from vision and touch telling you that your knee is growing. That's back to normal, and then we start to usually shrink it and make it look small and short. Okay. Oh, did that one not come up? Let's see, if you watch this one, it might play again. Let's see if it's on repeat. I never know how long this video is. Can you see on that one? That's hard to see, my apologies. But with this illusion, what we did is we tested people with knee osteoarthritis, and we gave them a ton of different conditions. And we didn't tell them, importantly, which one was the real illusion. We just did a bunch of things and just measured pain and really didn't tell them very much at all. And this is what we found, is that we found this interaction between the type of the condition, the type of illusion that we did, and time, which basically means that when we gave them the real illusion, they had this significant reduction in pain, and that change in pain was significantly different than what occurred in the controls conditions, in which there was no change in pain. So it does suggest that there appears to be this pain modulatory ability of changing how that body part looks to someone. And then I was interested in saying, well, if we just sustain this for a while, will pain continue to decrease? Nope, it won't. We tested that, it doesn't. It stays quite constant, but it doesn't continue to decrease. But what's interesting is that when we repeat these illusions, there does seem to be a cumulative effect. So this is when we repeated the illusions 10 different times. And I don't know if you can, maybe I'll point here. You have a pre and a post score for each illusion. And what I hope you can appreciate is that as we go along over time, we continue to get less and less pain. And so this is of someone, we did this one in standing, and basically did the illusion each time, and then measured pain scores. And so it does suggest that these effects are cumulative. So the next step with this is really to understand what is the dosage that we need of this to be able to impact daily pain scores. What do we need to do, or can we? Or is it that this is limited to the times in which we're testing? We also see that these visual illusions can have a role in this bad condition, this complex regional pain syndrome. So when they do movements with their hand, and the circle is peak pain during those movements, and the squares are post-task swelling in the hand. These are just two control conditions. But when you make the hand visibly look larger than it truly is, pain increases during the movements, but also post-task swelling increases. And intriguingly, when you make the hand look smaller, you have the opposite effect. Pain decreases and you have less post-task swelling. So again, this suggests that the way that we perceive and create our own sense of our body is incredibly important to its regulation, and that includes things like pain and potentially swelling. We recently did a systematic review trying to understand and get an idea of the level of evidence for bodily illusions in clinical pain. And what we know is the evidence is limited at the moment, but that when we look at changing the size and the shape of the body part using things like what I've shown you, they have sufficient positive evidence to support further study, but we need to look into it. Having prolonged mirror therapy has positive reductions on pain. And if you have lost a limb, immediate use of a prosthetic is much more likely to reduce your incidence of having phantom limb pain than not having a prosthetic quite immediately, which is quite interesting. And what I'm going to do for just the last couple minutes of this talk is I want to shift a little bit and just think about other bodily feelings such as stiffness. Because if pain is this protective response that's generated by the brain to, keep us out of danger and keep us from injuring ourselves, is it then possible that other feelings such as stiffness might be a protective response that is trying to stop us from moving or stop us from doing something, in which case it might not actually relate very much to the biomechanics of the back? Is that possible? Do we see this same disconnect between what's going on in the tissues and what people feel or experience? And so to test this, I first took a look at the literature and said, well, is there any evidence at all to suggest that there might be a disconnect between tissues and the feeling of stiffness that you have? And yes, indeed there is, in that a feeling of stiffness, you can have it even when you're missing a joint. So this is a study that people who had bilateral rheumatoid arthritis had to have an amputation of one limb and then went on to develop phantom limb pain. A phantom limb. They didn't have pain, these ones. But the researchers asked them about stiffness. Do you still feel stiffness in that phantom limb and in those joints? And the answer is yes. So you can see that the dotted line is in the phantom limb, that they still perceive a feeling of stiffness despite not even having a joint, suggesting that there has to be another contribution to stiffness than just from the joint. And what's more is it's not just a reflection of the other side, because if you do exercise, real exercise with the real limb, imagined exercise with the phantom limb, it reduces stiffness only in the limb that's being exercised. So this gave me quite an excitement towards saying, yeah, maybe we should question this and look at it a little bit further. So I recruited people who had chronic back pain and stiffness, and then we also recruited an age and gender matched control sample that didn't have chronic back pain and didn't have chronic back stiffness. And I chose bad pictures here because they appear they're not matched, but I promise they were. And we used a device called the indenter. It sounds like it should be in a Star Wars movie or something, but all it does is it applies a standardized force to a person's back, and it allows us to generate an objective biomechanical measure of stiffness of the back. And it's been shown to be quite reliable in these populations, and also is predictive of who does well with spinal manipulation therapy. So it does have some validity to it. And this is what it looks like. It'll apply pressure to the back. It looks really bad, but she's really flexible. It didn't actually hurt. But we get a measure of stiffness. And so what we asked was, okay, so when we measure objective stiffness of the back using this method, how well does it actually even relate to their feelings of stiffness? And it doesn't at all. There was no relationship at all, no matter what we looked at, between feelings of stiffness and objective measures of stiffness. Because I would guess if you felt you were really stiff, I would think that when you test your back, it would also be really stiff. And we also found no differences in those objective measures between people who reported feeling stiffness and people who didn't report any stiffness at all, which is interesting. One thing we did find differences between the groups was that people with low back pain and stiffness think they're getting much more force than they actually are. They overestimate it by about 60%. And this was consistent throughout all the testing. And we had trained them in estimating force, and that's how we got these measures. And what's quite interesting is how much they overestimated force related very well to how stiff their back felt. So that was interesting. So we took that a bit further and said, okay, well, if this feeling of a stiff back relates very poorly in our sample to the biomechanical state of the tissues, the way that we measured it, then we might be able to hypothesize that we could modulate perceptions of the back, because even without touching the tissue dynamics. And so we looked again at how we create a sense of our body. And what we realized is that sound, auditory information, is a really, really important contributor to the feeling of the body. And so we said, okay, well, in people that have chronic back pain and stiffness, and often anyone that has stiffness, they'll almost report as though they can hear, and in some cases they can hear, the creaky, grindy sound of movement. And so we said, well, what if we give them that sound when we push into their back? What would happen? So we did. So we paired with the pressure to the back the sound of a very creaky door. And I'm hoping the sound's going to work on this, otherwise we'll have to. And then it was the same sound on the way back up. So we did 4 conditions in a randomized order. There was the creaky noise, where we repeated that creaky sound over 3 different indentations to the back. There was a no sound condition, a control sound condition, where it was kind of just like a whoosh, whoosh, and then creaky decrease, where over 3 indentations, it got less and less creaky over time. And I'm only going to talk about the comparison of the 3 creaky sounds to creaky decrease, because I think that one was really interesting. And so what we found is this is how much the y-axis is how much they overestimate, how much force they estimated that they got, and a positive is overestimation of force. In the creaky condition, each colored bar is each of the different indentations pushing into their back. And you can see that overall, it looks as if the back pain people are still overestimating force, more so than healthy controls on the left. But actually, they weren't different from each other. And you can see that as we continue to give them that creaky noise over the 3 indentations, that force estimation, they think they're getting more and more force each time. And what's intriguing then is that when the creaky force decreases over time, we see quite a different picture. So particularly if you look at the back pain sample, the one on the right, you can see that just like before, they start by thinking they're getting way more force than they actually are. But then when that creaky noise decreases, the second indent, gosh, they're quite accurate. They're pretty much spot on. And then when it decreases again, it gets less creaky, they actually start to underestimate force. They think they're getting less force than they actually are. So merely by manipulating the nature of sound information that's being applied, we're manipulating their perception of their own back and what's going on around it. And the fact that these estimations of force related quite strongly to their feelings of stiffness suggests that we might be able to modulate these types of things by adding different body-relevant information. So the main difference that we did see between the conditions was for this last indentation, in which you can markedly see that there were major differences in how much force they thought they were receiving. So the implications from this, I think, are really that when you add this congruent sound information to pressure that's applied to the back, it's able to manipulate this perception of force. And it's this idea of credible, believable evidence. For the people, we chatted to them afterwards, and they didn't actually think that noise was coming from their back, thankfully. But when you pair things in time, the brain really, really likes to make them into one story. And so we take advantage of that a lot. And it raises the possibility, I think, that we might be able to use some of these things in treatment. So there's a really cool study done by Ebony Rio, who's now at La Trobe University, that was looking at getting people who had Achilles tendinopathy to do their eccentric exercises paired to a metronome. And literally just pairing those exercises to a metronome, they have better results. We don't know why that is. Maybe they're attending more. Maybe they're somehow combining that information and that matters. I have no idea. But I think it's an area that we haven't looked into in terms of rehab for participants. What's more is that this study found that the nature of the sound matters to the effect on perception. So it's an identical sound that we used. We literally are just decreasing the volume to make it less creaky, and yet we have a very differing effect on perception. And the fact that actually we didn't find any differences in that case between people who had back pain and healthy controls overall. They both responded to these sound additions. And that's actually quite cool, because what it means then is that in people with back pain, they have intact multisensory integration. They're able to integrate information from different sources, and that's important potentially for treatment. So I'm going to follow up with the take-home message, in that I really hope that I've conveyed that pain is an incredibly complex phenomenon. and that what is going on in your brain can be, and I'd add nervous system to that, brain and nervous system, can be more important sometimes than what's going on in the painful area, particularly when it's a very chronic condition. And that's always a fine line to walk because we're never suggesting that pain isn't real. Of course, it's 100% real, but that sometimes maybe we're targeting the wrong spot. And I think what some of this research has done for me personally is to question some of the ways that our treatments might be working. Maybe they're not working for the reasons that we think. And that's okay. But I think what's really interesting is for us to continue to delve and to continue to look in to understand how they are working, because then we have that ability to make them better. Also, this idea that in chronic pain, there are so many changes going on in the nervous system itself. And that really does mean that the message that's going to the brain, or in some cases, how things are represented in the brain, is not indicative of how much tissue damage there is. And being able to communicate that, I think, to people is a really, really important skill. Because there is evidence to suggest that targeting how people conceptualize pain is important, because when we educate people about pain neurobiology, it helps. It reduces pain, it increases function, it improves movement, and those are all really key outcomes. In addition, we're just at the start of this growing body of evidence to understand the importance of how the body is represented in the brain and how that relates to pain. We see that targeting the precision of localizing things appears important and can reduce pain and improve function. We also see that by manipulating how the body part looks and feels to people has effects on pain. But the real next step, I think, here is that we need further work in this area before we know how to properly apply this clinically, and indeed whether it should be applied clinically. But I think the nice bit is that there are easy ways to kind of play and try this in your own practice. Things like having binoculars and turning them backwards, and it will minimize the size of someone's body part. Maybe in people that are doing things that are really struggling, you can have a bit of a play and see how they go. But overall, I guess, I think we're actually in a really exciting time, because there's a lot of really new research that's going on that has the ability to alter practice. And as people that are getting to talk and getting to spend time with patients, it's such an important role to be the ones to potentially bring that new information to them. So I want to thank you so much for your attention this morning, and to all the people I work with and my funding sources. Thank you so much.
Ladies and gentlemen, Dr. Tasha Stanton. Before we break for morning tea, we do have about 5 minutes to open up to questions from the floor. If there is a question that you've got, there's one straight up the back. We'll start there, then we'll jump over here.
I suppose mine's going to be reductive questions. I suppose working in the cold place is really where we're doing our treatments. Patient information is one thing, but clients expect us to touch them. So I'm wondering about things like encouraging them and asking for reception and intersection, like maybe touching on people and asking them to move and so on. Is that a good approach?
I think that's a great suggestion, because I think you're exactly right, is you bring in also patient expectations of what they're coming to get. And so I think you hit the nail on the head that if you just focus on education and didn't touch someone, they're probably not going to go away a happy customer, I'm guessing. But what would be really, I think you bring up a very interesting point about what we do when we touch people. Because I think there's certainly, you get that affective component, that feeling of connection that is good for them, and they feel as though you're doing something to them, which I think you are, and that's very important. It's interesting to consider, how I guess you could integrate some of the things. For one example was, I know there was an acupuncture study that was looking at different locations of the needles, and they had people, when they did the little twirl, to discriminate what location that twirl of the needle was occurring at. And I wonder, or stimulation of the needle. So I wonder whether a similar thing might be kind of interesting to look at within, let's say, if someone has back pain and you're touching different areas and you're actually getting them to identify to you where they're being touched. It would be quite intriguing to see if that had any impact.
We have a question just down here, and then we'll jump over here. Sir, I might just grab this microphone.
Oh, of course.
That's right.
I'm very interested to know, clinically, are there things that we can really do to keep someone feeling very safe? And are there perhaps some examples of things we shouldn't do that could really make their pain worse?
Yeah, it's a really hard question. I think it's partially hard because, as you well know, everyone's so individual. And I think it really takes trying to focus in on them, what sort of things for them are danger signals in terms of what did they associate being dangerous with what's in this situation, or maybe what they're planning to do. But then also, what do they associate as safety signals, I guess, as well. And then whether, when you're looking at some of those, the things that they do associate, and that might be a literal conversation, whether you can challenge any of those, but challenge them in a way that is not saying, oh, yeah, of course you're wrong, this isn't dangerous, but giving examples and giving, so one example might be if they're, don't want to do this one action because they're really scared that the pain will increase. If you're there and you're saying, well, what is the very worst thing that's going to happen? Pain is going to increase. Is there anything else that's going to happen that will be terrible? Well, no, pain will increase. Well, what if I'm there and we just go through that pain increase together and we talk about it? And it's interesting, one of my colleagues, Dave Moen, he works as a physio in a clinic out of Adelaide, he's done that idea kind of pulling on the classical conditioning type literature, in the sense that if you can make them realize, or not make them realize, but help them to realize that this is the very worst thing that can happen, and we're there, and I'm making sure you're safe while you're doing this, so we're not worried about that anything further is going to happen. If we go through this, is it possible that we can start to extinguish maybe the anxiety that's related to that, which then may then also reduce the pain? In terms of things, the second part of your question of what potentially not to say, I think sometimes it can be really, I think words are really, really powerful in terms of how we talk about imaging findings, because I think oftentimes it's a literal picture of what's going wrong, and things like degeneration, they're scary words, because I think if you don't have a health background, and even if you do, it might not be completely clear what that means, but we know that a lot of the things don't relate. Like if we took a look at my back, I don't have any back pain, but I would have degeneration. So I think it's probably just being very careful, and when people bring in findings, maybe imaging reports, probably it's good to acknowledge, but probably not focus, I guess, on those. But thanks, that's a great question.
Question. So I promise this one, then we'll come to you. Sir.
John Mason, I practice in Canberra. I've always been concerned about possibly unreasonably raising people's expectations. If they say, oh, that feels a lot better, John, it's always, well, hopefully that will help. Now, according to your research, that might be a bad way of doing it. Perhaps I should be saying, oh, yeah, that's fantastic. I'll write this up for the journalist. In other words, if I put a positive spin on this is not being phony. It might just help. Is that the case?
It's really interesting, because I think you ask a very good question, in the sense that keeping people's expectations too high also can have detrimental effects. It's like when a friend tells you that there's this fantastic movie that you have to go see, and then you see it and you're like, I'm so disappointed. And probably if they didn't say that, you wouldn't have that disappointment. So I think you hit the nail on the head, that it's probably a line between accurate expectations about things, and it might not be more so about being a little bit reticent about the outcomes that they might get from that, but I think it might be challenging beliefs before the treatment occurs that this isn't going to help. Does that distinction kind of make sense? Because I think you're exactly right that we run that possibility or that risk of promising too much, and I think that can be just as hard and can have opposite effects of what we might like to have. Yeah.
My guess is it was an Adam Sandler movie. There we are.
Thank you so much for that talk. That was just brilliant. But I'm also wondering, like, there's the work of Norman Deutsch in relation to the brain, how it changes and everything like that. If any research exists in this area with, say, if you took a person who had been visually impaired or deaf, what would then happen to these pain perceptions? Because they've never necessarily had that expectation as a control. Like it would be, I'm just wondering whether there's any research or...
It's a good question because I think there certainly is research to suggest that when people have been visually impaired their whole lives, they do have enhancement of different senses such as touch, and obviously through braille use. Whether or not they would get, I wonder whether they may have differential weighting of the value that they, or the weighting that they put on information coming in from different senses. So if they don't have vision, let's say in a lot of those we're manipulating vision, but they might have stronger senses in terms of, or weighting of proprioception. And that's one that we definitely can use different types of illusions. So we have played with the idea of creating this sense of a finger growing by using tendon vibration. So when you vibrate a tendon, if you fix the hand so it can't move, the vibration of the tendon gives the brain basically wrong information, and so your brain projects a sensation that your arm is moving. So if the hand is fixed, if it's not, it literally will move your arm. So if you vibrate at the elbow, and you have people, let's say, hold their hand like this, and they hold like this, and you vibrate, you can give them the sense that their finger's stretching through another type of illusion, using the senses that they're probably weighting heavier. In terms of perception and how it would affect their daily life, then I wonder if they're the ones that, instead of vision being a cue for things, they have a very adept sense of proprioceptive cue. And I wonder then whether actually they, when they're in pain, wouldn't have those same dysfunctions in those maps. Or if they did, actually we'd probably be able to pick it up very quickly because I would guess you'd be quite impaired considering you rely so heavily on them. So I don't think we know the answer in short, but I think it has a lot of interesting possibilities to look at.